So here's the physiology of hormones and target receptors. We're not going to talk about specific hormones or specific endocrine glands. We've got to talk about the hormone, which is maybe a key, and it needs to go into the receptor of this cell. We've got to talk about the hormone go into its receptor, and its goal, its action is to open up the door. What we have to talk about is what happens within the door. What is the mechanism to actually unlock it? And that's the part that gets a little dry and boring. But we'll talk about it, and I'll show you the significance of it too. Now, you all know the differences between the nervous system and endocrine system, compare and contrast, which I talked about a few moments ago. Okay, just make sure you can do that. Now, hormones, there's a lot of hormones. You won't have to worry about all of them, about half of them, about 30 to 35. I think in the endocrine system, we're going to go over about 25 different hormones or so. And then throughout the rest of the course, there's another 10 that we're adding. Because believe it or not, the small intestines releases 2 hormones. But I don't want to get into that until we get to the digestive system. And these are the glands and the hormones that it comes from. So it's a nice summary slide also. Now, let's get back to communicating from one cell to the other. I have my family in New Jersey. We have ways that we can communicate with my family in New Jersey. I could call them up, for instance, and talk to them. I could send an email. I could do snail mail. I can drive over there and talk to them. There's different ways to communicate. And your body has different ways to communicate from one cell to another. For instance, we have hormones. And the gland gets to release one of its chemicals, which in this case is the hormone, directly into the bloodstream to go to wherever it needs to do to find its receptor, as we're going to talk about. We could also have something called an autocrine and a paracrine. An autocrine is a cell that looks like something like this, and it releases a hormone, a chemical, we'll call it a chemical, that goes not into the bloodstream, but another nearby cell that is the same exact cell it is. We call this an autocrine chemical. Okay? We can also have another chemical coming from a cell, and it goes to another nearby cell, that doesn't look anything like it, but it's right next to it. In this case, we call this a paracrine chemical. It doesn't go into the bloodstream, it goes to the next. We'll show those examples. I guess the pancreas is a good example. We'll show you those later. We also have pheromones. Pheromones is a chemical that comes from an organism. And it goes into the environment, and it changes the behavior of another organism, whether good or bad. Pheromones. Ants release pheromones to the environment, and those pheromones will tell the worker ants to stay on track. Don't go off on another tangent. Stay in line. We have pheromones that get released from our body called BO. Are you familiar with that? BO, body odor. Those are pheromones. That gets released. Yes. You were in the class? Okay, you weren't here Tuesday. Okay. Talk to me after class. We'll take care of that. So we have BO, and that's a pheromone. It's a chemical that gets released from our body, goes into the environment, and it changes the behavior of another organism. Now, in our culture, American culture, that usual behavior is going to be something like, right? That smell is not something that's suitable for us. Okay? In other countries, they like that smell. And it's actually very attractive for them. But we have that. We have more or less artificial pheromones that we spray in our body to get released, right? Perfumes and colognes and stuff like that. Okay? Cats in heat release pheromones to get the other male cats closer to them. Okay? So those are what pheromones are. Then you have a neurohormone that is a chemical that's made in the nervous system but acts like a hormone. And the two examples of this is something called oxytocin and ADH. They are made in the hypothalamus, but they act as hormones. They get released someplace else. And we'll talk about those later. And a neurotransmitter you learned about in AMP1, so I'm not going to bore you with that. It gets released from a neuron to go to, let's say, a muscle or another neuron, right? So these are pictures of showing exactly what I just showed, what I just explained. Here's an autocrine, here's a paracrine, here's a hormone that kind of gets released over here right into the bloodstream. All right, this is a neurohormone where the hormone is made in the nervous system but acts like a hormone, goes into the bloodstream. Neurotransmitter going from one nerve cell to another, and here you got two little rats in love because of the pheromones. Okay? Make sense with those? Those are words that we're going to be using throughout the rest of this semester. Okay. Now hormones, and that's what we're going to gear ourselves on, is hormones. Hormones are defined by what they do, not what they're made up of. Hormones go directly into the bloodstream. That's what a hormone does. But they can be made from a lot of different things. You could ask me, is a hormone a protein? Yes, some are. Is a hormone a steroid? Yes, some are. Is it a peptide? Yes, some are. It's not what they're made up of. It's what they do. Now, it's helpful to know what they're made up of and how they act. They're still going to go into the bloodstream, but they have a different mechanism to get into the bloodstream. Now, I am not going to ask you which hormones are proteins and which hormones are peptides or steroids. There's certain ones I want you to know, and they're pretty easy to understand which ones, but I'm not going to ask you a laundry list to memorize those. Okay? The steroid ones are pretty easy. They're all the sex steroid ones. Testosterone, estrogen, progesterone. If it ends with an "-one", it's going to be a steroid. So we'll talk about cortisone. We'll talk about aldosterone. All right? So when we get into these, you'll see what that is. Okay? And these are kind of like what they look like, just to, and you're not going to have to draw these out, but just to show you there isn't any typical form of a hormone. They could be a cholesterol or a testosterone like this, right? Steroid. They could be a protein up here. It's not what they are, it's how they work that makes them a hormone. Okay? So locally acting chemicals, paracrine, autocrine, we kind of talked about that with the pictures I put up here, so I don't want to bore you again with that. Now, how do hormones get secreted? What are their stimulation to get secreted? Well, there could be three different ways. Either a neural reason, stress will make something come out. It could be some sort of hormonal reason. A hormone is going to make another hormone to come out, kind of like what I showed you earlier over here. Or some other substance that's not a hormone is going to make something come out. Like glucose. That's not a hormone, but the substance, the properties of glucose is going to make a hormone come out. Or calcium. That's not a hormone. It's some other non-hormonal substance that's going to make a hormone come out. Okay? So those are the three ways that hormones come out. And you can read this on your own, it's just what I explained to you. This is where the neural reason comes out, and this is where the non-hormonal reason comes out, like glucose. But what I want to spend a little bit more time on is the hormonal reason. Okay? And we'll draw this up again for you, the hypothalamic pituitary target axis. So there's the hypothalamus, anterior, posterior pituitary, and we have, let's say, the thyroid. It's not always going to be the thyroid, I'm just using that as an example. And we have a hormone that comes out of the hypothalamus. This will be TRH, right? Thyroid releasing hormone. Tells the anterior pituitary to release another hormone, thyroid stimulating hormone, to tell the thyroid to release its thyroid hormones, specifically something called T3 and T4. These will actually make your metabolic rate go up. Okay? You could, lose weight, use more energy and stuff. Now, we have something called negative feedback that is going to try and control this so that we're not going to have an overproduction of TRH or TSH or T3 and T4. Remember, it acts like a thermostat. We have a thermostat, the endocrine system, that is going to make sure that your temperature in your house is going to stay at 70 degrees. It's not going to go up to 80. So I'm just going to bring it back down. So, this is a little review from AMP1. Homeostasis. Okay? Homeostasis, there's a set point that you want. Like your temperature of your house, 70 degrees. That's what we want. So it's our set point. But we have a normal range. If it goes to 71, that's okay, right? It's around 70. Well, use your body temperature. Your body temperature is 98.6. That's our set point. But if it goes to 98.9, that's still normal, right? You've got a normal range. If it goes down to 98.5, that's still normal. Okay? There's a range of values that we have. But we want to get it back to the set point if it goes out of this normal range. So we have two mechanisms that go on in our bodies. There's something called negative feedback. Negative feedback is going to bring that temperature, if we're talking about temperature, closer to the set point. All right? Let me use, there's so many examples. Let me use an example of glucose. Okay? If our glucose level is supposed to be 100, all right? And now it moves up to, let's say, 120. And then it goes to 140. If it goes up to, let's say, 120, something needs to bring it back to 100. That's negative feedback. We have a system to get it back. We are making this distance from the set point to what it is now smaller. It's not getting larger. Does that make sense? Likewise, if it goes down to, let's say, 80, goes down to 60, negative feedback, if it goes down to 80, is going to bring it this way. It's making that increment smaller. Is that clear? And we have a lot of negative feedback in our bodies. It's always going to happen like that. You want it. Otherwise, if it keeps on going, we got problems. Now, we do have something called positive feedback. Now, positive feedback is not oftenly occurring in our bodies naturally. There are some places, and it's referred more towards the reproductive system, which we'll explain when we get there. But let me give you one example of what normal is. The set point to the cervix of the uterus. The cervix is the opening to the uterus. Normally, it's closed. That's its set point. But when a baby needs to come out, that doorway has to open up. So as the baby's coming out, that cervix is going to open, going further from that set point, right? The set point is closed. But you have to have it opening. It sends a message to the brain, says, oh, the baby's coming out. Okay, we're going to send a message back to the uterus or cervix and give you more pain, so that we can open up more and more and more to push the baby out. So this is going further from the set point. Does that make sense? But in that case, you need to have that happen. Otherwise, the baby's going to be corked up there. All right? And there's some other things. When we get to estrogen and menstrual cycle, we'll talk about more positive feedback, but that's too advanced right now. But we'll get there. If we have positive feedback happening in our body, in most cases, it's a disease process. If your normal glucose is 100, and now it's 120, and now it's 140, it's going further and further and further away from the set point. That's positive feedback. Something's doing that, and that's not what you want. That's diabetes, for example. It's going further. You're going to have high levels of glucose. So positive feedback overall is some sort of disease process going on. Not all the time, most of the time. Is that clear? Okay? So this is just showing you negative feedback. They're doing the temperature of the house. They're using 22 degrees, but that's Celsius. All right? They're trying to get it back in there. So let me do, I'm going to do this for you up here. Yeah, okay. All right. Now, I do a lot of clinical stuff in my lectures. This is no exception. This isn't really in my notes over here, but it's in my lecture, and when you watch it, you'll see it again. But I want you to understand the concept here, and you will be asked on exams about this. So I want you can put your pencils down if you want. You have it recorded, you can watch it. But we're going to do like in the next 15 minutes, I want to do a little interactive thing with you. But let me put things straight over here. And this is where we're going to talk about things like cancer. Let's talk about cancer for a moment. In essence, here's two rules of cancer. One, it doesn't follow rules. It has a mind of its own. All right? If someone tells it to stop, it will keep on growing. Does that make sense? Overall, rule of thumb is that. There are some cases it doesn't, but overall. The other rule about cancer, if it's of a tumor, if it's of, let's say, a gland, then overall what's going to happen is, if there's cancer of the anterior pituitary, it's going to produce a lot more of those hormones. If this gets bigger, more hormones come out. Pretty easy to understand that. Okay? Now, let's talk about what's happening here and how to utilize negative feedback. Just memorizing it is one thing. How to use it for all your other courses you'll be taking for the rest of your life, that's what's key. And I do a lot of that to show you the significance of this stuff. The hypothalamus releases TRH, tells the anterior pituitary to release TSH. TSH then tells the thyroid gland to release T3 and T4. This always goes on. But you don't want it to keep on going on because you're going to have too much T3 and T4. Does that make sense? So we need something to slow this down. So what happens here is that when T3 and T4 reach a certain level, and you don't have to worry about what that number is, but when it reaches a certain level, it says, whoa, we got too much T3 and T4 down here. It says to the high people, hey, guys up there, don't make us make any more. We got too much of it. How does it do that? It sends a message to the anterior pituitary and the hypothalamus to slow down. Now this is going to decrease. This will decrease. And because this is decreasing, this will decrease. Is that clear? I'm going very slow at first. Then it gets to a level, because this is not making that much, it gets to a level that's very low. So the thyroid says to these upper ones, hey, we need more. We got too little down here. So it sends negative feedback to each one of these and increases it so that it goes up. It's a big teeter-totter. And that's what negative feedback does, to make sure that the T3 and T4 are at an adequate level. Is that clear how this is working?
How does it send the negative feedback by hormone itself?
Right. Yeah, it sends a message to the brain to do that. Yep. Okay? The levels do that. And we'll talk about downregulation, upregulation too, where that comes in. Now, we clear with that. Now I'm going to throw in clinical aspect. Things that maybe other teachers wouldn't do. Because I think you might forget about that. But now I want you to see how to use this. Let's say you have a thyroid tumor, cancer. Because the thyroid is cancerous now, how much T3 and T4 come out? A lot, a little? A lot. So this sends negative feedback, because it's a lot, to the hypothalamus and the anterior pituitary. How much of the TRH is going to come out? Little. There's so much of that, it's saying, we don't need any more, stop, stop, stop. And that also tells the TSH to come out. Now there's a decreased amount of TSH that goes over here. So how much T3 and T4 come out? It's cancer. Still a lot. Because it doesn't listen to the other hormones. Do you see what's going on here? Now, if someone's got an overactive thyroid, they're going to do something called a blood test called thyroid function test. And in the thyroid function test, blood levels, we would need to see blood levels of T3, T4, TSH, and TRH. If we see levels being very low here, very low here, very high here, we know that the problem lies in the thyroid. Let me give you another example. There's a condition called Graves' disease. Who has heard of Graves' disease? A few of you. Okay, we'll talk about it when we get to thyroid later on. Graves' disease is an autoimmune disease, meaning that your body is going to make antibodies to attack yourself. We've seen an autoimmune disease called multiple sclerosis, right? You've seen that in nervous system, where your body is going to attack the myelin on the neuron. Why does it do that? We don't know. I mean, we know why it's doing that, but we don't know why you're producing these autoantibodies to attack yourself. Well, in Graves' disease, it makes an autoantibody. Now, let me just show you something here. Just give an example. TSH may look like this. All right? And this piece here will fit into here, like a lock and key. This portion goes right in here, and what it does, pushes the button to release T3, T4. Right? That's the receptor, that's the hormone. We clear with that? An autoantibody that Graves' disease releases, so this would be, let's say, Graves, it may look like this. But its portion that goes into the receptor looks exactly like this. It's an imposter. And this is going to go in here and turn this on. Is that clear about that? If it does, it's going to make T3 and T4 go up. We clear with that? Just the way a tumor would do. So if this goes up, what's going to happen to TRH? Down, right? What's going to happen to TSH? Down. What's going to happen here? It goes up. But a different mechanism, not because it's cancer, but because there's some kind of imposter that's turning that on. Clear with that? Now,
So would that be positive feedback check?
that would be positive feedback. Something's, it's getting further and further and further from the set point. That's positive feedback. Like I said, most positive feedback, there's some kind of condition going on, disease. Now, how do we determine if it's cancer or Graves' disease? That's where we got to go further test. The first test we're going to do is the blood test, thyroid function test. We're going to see what the TRH is, the TSH, and the T3 and T4. We know that the problem is lying someplace with the thyroid. We don't know what it is. So now you do the next step. Let's do an ultrasound of the thyroid and see if there's a tumor there. An ultrasound is just, if you had a baby, it's that gel that they put in here, and they can see if there's any lumps and bumps that they can see any tumors. That's how you can test. How do you test for Graves' disease? Well, we can actually do a blood test to test for this. But this test costs like $500. The ultrasound costs $100. This is where insurance companies come in. They are not going to say, hey, look, you doctor, Mr. Doctor, Mrs. Doctor, whatever. They're not going to say, okay, you think it's something wrong with the thyroid. You are not going to do thyroid function test and ultrasound and the test for this, because that's too much money. You've got to follow step by step. Because if you do the thyroid function test and that's finding out it's normal, then you just wasted money on this and on the ultrasound because you know it's not because of the thyroid. They'll tend, if you get a thyroid function test and you see this setup on here, the first thing you'll want to do is the ultrasound, because that's the cheaper one. If it comes back normal, then you'll go into this $500 thing. You see how you're utilizing this? Yeah? Let's give you one more example. Let's say someone has a stroke, which means that they're going to have less blood flow to a certain part of the brain. And let's say they have a stroke that destroys the anterior pituitary. Okay? Not all strokes do that, but let's say that's what the blood flow to the anterior pituitary was compromised. Now look what's going on. TRH goes up. TSH. How much TSH is going to come out? Zero, very little. Depends on how bad the anterior pituitary is compromised. But very little. How much T3 and T4 come out? Very little. Less of this, less of this. If this is very low, it sends negative feedback. How much TRH comes out? A lot more. How much TSH? Very little. And then this is very little. Now look at the thyroid function test. You see how it's different? When you have low levels of T3, T4, low levels of TSH, high levels of TRH, you know the problem's not here, the problem lies someplace here. Is that clear? You see how you're using this stuff. This is the stuff you need to remember when you get into your other classes. But you need to understand how it normally works. I always have to put diseases in this thing, not to add more mayhem to you guys, but more or less because I want you to understand or give the normal stuff meaning on how to apply it. Okay? Yeah.
Going back to for disease, there's still going to be a difference between Graves' disease and itself and just hyperthyroidism. So, like if your thyroid is overactive, that can be a response to hormonal imbalance due to pregnancy.
Right.
But that's not necessarily Graves'.
It's not. When we do thyroid function tests, there's other levels in there, which I don't want to get into. Reuptake T4. There's a lot of other things, free T3. I don't want to get you too confused with those other things in there. We can go, I'm just giving you like a start, an introduction to some of the pathophysiology, but you're absolutely right. I mean, we know that she's pregnant, and that's probably the reason why the T3 and T4 are changing. But overall, this is what I want you to understand over here. I don't want to throw in too much. It's enough to say, hey, look, when you get into these other fields, they'll expand with it. But it gives you some idea on how to use this stuff. You clear with that? Yeah? All right. I'm sorry?
Is it like a cure to Graves' disease, or is it being the fact that it's autoimmune?
Well, it's autoimmune, so we could do some radioactive treatment to this to try and cut down this. We could go to the source and try and make you have less antibodies. But if you do that, it's going to, when you make less antibodies, you're now more for other diseases to occur. So it's autoimmune diseases are a very difficult thing to control. You give corticosteroids, but then you have a lot of other things on it. And we'll definitely talk about that when we get into the immune system. Why it happens, we don't know. We'll talk about lupus. We'll talk about all these other ones too that are autoimmune. Okay? Questions about this? Okay. So these are just some summary slides, right? This is showing you the whole HPT axis. Okay? Gets busy. I only showed you here with thyroid. But this can also explain why estrogen levels are very low when we get into menopausal states. Okay? It's very similar, and we'll get into those later on. Okay? Positive feedback, the example I gave was when the cervix was opening, it's going away from the midpoint, or the septum.